Take this talk further of type 1, type 2, type 3. So I concentrate on type 1 and type 3 CNVM and how to differentiate. I think we can quickly go through these slides because we have had this discussion. Type 1 growing or proliferating under the RP, type 2 above the RP, and type 3 is basically an intraretinal NV, which is also what we call the RAP lesion. And it is definitely common enough for us to think about it and discuss about it. Almost 1/3 of the lesions in a patient with AMD may have RAP lesion, and it has been described variously by different authors over the last few years. Few common pathological or pathogenesis theories which I have brought forward is that the first step involves that the vessel origins in the deep retinal plexus, and the main vector of growth is downward, and the type 3 vessel which originate in the retina later on form a choroidal connection. So the origin is retinal in these cases, and because of the retinal origin, we are now beginning to call this as NV, neovascularization, rather than a choroidal neovascularization. The few salient imaging features are a focal hyperfluorescence on FA and a dipping of the vessel at a right angle, which can be appreciated in some cases on FFA. ICG shows hyperfluorescent hotspot, and these hotspots have been classified into various types by previous authors. This OCT staging, which has been recently defined, includes a precursor lesion, which is just a hyperreflective foci, which is above the RPE, and it may have a subtle downward deflection of the OPL. Stage 1 shows an intraretinal hyperreflective density, and this downward deflection of OPL is much more significant now, and the cystoid spaces start appearing in the inner retina much before the RPE is disrupted. So the disruption of the ellipsoid zone and the RPE happens only in stage 2, and the infiltration through the RPE leading on to a serous or a mixed PED is in the stage 3. So this is vis-a-vis what happens in a type 1, where you start with a pigment epithelial detachment. OCTA shows you a small tuft of high flow tiny vessels in the deep capillary plexus. So why is it a challenge? Because some of them are very subtle signs in the early stages, and unfortunately once it reaches the stage 2 or stage 3, it may become difficult to differentiate it from a typical type 1 CNV. Important to differentiate it in the early stages, because this is an example that I took from one of the published literature. It shows that regression of this hotspot and remodeling of the vessels can happen if treatment is initiated in the early stages. So with this, I bring out some differentiating points between type 1 and a type 3 CNV. And type 1 NV originating from the retina, and type 3 is originating under the RPE, the vice versa, type 1 under the PED and type 3 in the retina. So type 1, in the fundus examination, you can see it almost may appear near normal to begin with, other than a subtle elevation at the fovea or in the macular area, which you may see. Type 3, the patient may present with intraretinal hemorrhages in the early stage, and in the late stages, you may have this large pigment epithelial serous detachment. Type 1, a speckled hyperfluorescence on FFA and a plaque on ICG is what we have discussed throughout the day. A type 3, you will have this typical hemorrhages, splinter hemorrhages, because they are in the inner retina. And in the late stages, you will have this typical formation of an RCA, which will give you the diagnosis in the later stages of a RAP lesion. Coming to the early features, HRF, we saw that they are very important where type 1 CNVs are concerned, because just above the pigment epithelial detachment, when you see these hyperreflective foci, this is where it could mean that we are going to have activation of the disease here. But here you can see in a type 3 lesion, the hyperreflective foci may be the first, or the precursor stage itself may show you the hyperreflective foci. So in type 1, you have this subtle elevation here of the pigment epithelial detachment, and here you see there is a downward movement in the early stages of the OPL. This is what we call the retinal descent or the retinal subsidence, which is seen typically in type 3 CNVM. In type 1, the intraretinal fluid we know is associated with poor prognosis because here you see it in the much later stages. Vis-a-vis the type 3 lesion, in the first or the second stage itself, you may have cystoid spaces or the intraretinal fluid, which may go away with treatment very quickly. The subretinal fluid is very often and much more in amount in cases of a type 1 lesion. Type 3, you may actually have eccentric, not only necessarily associated with the lesion itself. Then here again, you can see the disruption of the outer retina may happen in the later stages. Here, the disruption of the RP is seen in once there is a retinochoroidal anastomosis which is forming. Pigment epithelial detachments can be fibrovascular in type 1, can be serous in type 3. Rips are more common in type 1 as compared to type 3. Multilayering is more common in type 1. We don't see this at all in type 3 lesions. Geographical atrophy is common in type 1, almost always present in a type 3 lesion. Response to treatment, usually lesser injections are required for a type 3 lesion as compared to type 1. Recurrences are less common in type 3 as compared to type 1. So you need a better treatment plan and you need to distinguish these two entities. OCTA patterns are really different in early stages. This is a typical type 1 lesion which may be much larger in size and has been described as a medusa or a C-fan appearance. Type 3 CNVMs in the retina is what we see in the DCP, and they are much smaller in size. But in conclusion, it's important to differentiate between the two because the treatments may be different and your approach to these cases may be different. Thank you.